Why don't we go ahead? Oh. Roll call.
Yes, I do. We have President Senator Brian Townsend, Secretary Claire DeMatteis, Insurance Commissioner Trinidad Navarro, Secretary Rick Geisenberger, Mr. Wayne Emsley, Mr. David Craig, Mr. Jeff Chastner, Mr. Michael DeGatto, Representative Bill Overly, and Denise Allen. Double check and see anyone else is joining. Yes, she's online. Great. So we do have good form.
Good. We have quorum and we don't have Joanna. How about that? Right. How did we let her take a vacation, right? Well, let's get right into approving our minutes, right, from July 10th, which seems like yesterday. Oh, Denise?
I'm going to speak up and saying I cannot approve the minutes. I have a question or a concern in there.
All right, well, I have to get a motion first.
Motion to
Okay.
approve the minutes.
Motion, and do I have a second?
Second.
Okay, now we can have discussion. So what is your question, Denise, or comment?
Well, I couldn't approve them because on page 3, it states that the subcommittees were generally in agreement to grandfather current retirees in the Medigap plan. And then it says, and offer a choice between Medicap supplement or Medicare Advantage to current and future employees. And I'm going to speak for myself. I listened as that discussion was had. And I was listening out of professional courtesy to the speaker, but I in no way was in agreement of the choice of choice. And I don't know if anybody else was there, but I was not in agree, but did I speak up? No, because it wasn't the time or the place to do that. We were just having that discussion.
Right, so we could easily we should just wordsmith it. Go ahead. Yeah.
So my
let's change that.
suggestion is on the second line, put a period after special medical plan, so generally in agreement of grandfathering. And then the next sentence would be, some members appeared in support of offering a choice between Medigap supplement and a Medicare Advantage to current and future.
Excuse me, is that exactly what happened, or are we just making things up?
Yeah,
Yeah, I don't recall that.
I
don't recall that.
so I think.
I'm fine going further. I just.
Yeah.
The minutes
I offered this.
approved as submitted.
All right, if I could have order, I think we'd get my gavel from the Senate. Yeah, all right, gentlemen, I hear this, I think Paul is trying to be a good editor. I hear dissension. How about we just say subcommittee members discussed grandfathering current retirees. I mean, we could put it very simplistic. Grandfathering retirees into a Medigap plan modeled after the current special medical plan, or however you want to wordsmith it, period. Or we already
What
said.
about, and discussed offering a choice between, is that?
And that's Lieutenant Governor, frankly, I had highlighted the same thing. I
Okay.
think we were in general agreement on the first part.
About
of the statement.
grandfathering.
Yes. It was the
People were in
second
agreement
one,
with that.
and I had thought along the same lines that we had a discussion on that,
Discussion, it
but
was
there clearly
never
was not general agreement.
Yeah.
No, I-
concur. So did you capture that?
So
No,
is,
I didn't.
so Craig, I think just between and offer,
You got it?
So
and
did you
discussed offering,
you want to read it?
I think it's just 2-word change.
Do you want to say it?
Okay, I got it. That you guys discussed offering a choice, but there wasn't any kind of like
But
There was,
agreement one
there was
way or the
not.
other.
leaving the word about the agreement for grandfathering. And then the next
Separately.
thing is, and discussed offering. the choice.
Agreement with grandfather, discuss option.
Secretary has.
Secretary
For the
Geisler.
purposes of getting the minutes done, I'm fine with that, but I mean, it is accurate to say that there were members that did express support for
Right.
having a choice. Having a choice. It's accurate.
And it depends on what choice right means. Right, so how did you word it?
Point of order, you don't change.
And discuss.
And discuss offering,
You
okay.
don't add a new section.
Thank you, Denise. All right, so the edits have been submitted as such. Do you want to repeat what they say, or is everybody comfortable?
Yeah, could we just go?
Yeah,
through
go
it
ahead.
so I
You want to
can
say
really
you have it right
understand?
now?
Yeah, so the grandfathering people were in support of And.
Not grandfathering people in support.
I
Go, why don't you do
how
it?
about I read the paragraph? This is how I read the paragraph. Edited the paragraph. Subcommittee members were generally in.
Not, I don't even have to say generally, don't even say generally, discussion or.
No, I think that's fine.
Okay.
Subcommittee members were generally in agreement to grandfather current retirees, right? Into a Medigap plan modeled after the current special Medic-Fill plan. And discussed offering a choice between a Medigap supplement plan or a Medicare Advantage plan to current and future employees upon retirement.
Was it current? I don't think it was current. Was it current?
There was
Absolutely,
discussion
absolutely,
about
absolutely.
offering it to current retirees, not
All right.
requiring it, but offering.
All right. The discussion.
And discussion.
All right, Denise, thank you. We got clarification. So motion and a second, all in favor with the edited version of the July 10th minutes, signal by saying aye. Nays? And abstentions, anyone? All right, thank you. Now that we have the minutes approved, let us move right into our combination and discussion of OPEB funding, eligibility and plan designs. So Faith, are you taking this away?
Well, I think we're gonna have a little bit of a tag team on this morning's discussion. If I may suggest, before we get into the larger slide deck that outlines the various options for funding eligibility changes and plan design, would the subcommittee perhaps be inclined to allow Willis Towers Watson first to review the Medicare supplement plan design options slide deck?
Sure.
I think, or at least I'm hopeful that this is going to address some of the questions and requests by subcommittee members to further look at possible future Medicare supplement plans and what they would potentially look like for future retirees and or new hires when they retire, compared to the existing plan design for today's special Medic-Fill plan. So if the group's in agreement with that, we can start there, and then I think that will hopefully move us into additional discussion on the combination options.
I see thumbs up and nods. Go ahead.
Can I add just one point? In the slide of the 50th percentile that was shared, the number at the bottom for Medigap N differs by about 33% from what WTW shared on slide 12 of their April 3rd presentation. So I'd like them to also be able to talk about that if that's possible.
I think that is possible, and I do want to call out to subcommittee members and as well as individuals participating today from the public. There was a version of this presentation posted and distributed yesterday afternoon. It did not include the 10th and 90th percentiles for Medigap N and L, which was included in the deck for the 50th percentile. We are going to be using a slightly updated version of the materials for the discussion this morning. And that presentation will be posted publicly and distributed to those subcommittee members shortly after today's meeting. So just want to level set on that. That was a good call out. We were still working on trying to pull that together when the materials went out yesterday.
We appreciate it. And I do want to acknowledge that to our committee, and I know you all do. I mean, we've asked a tremendous amount with Joanna and our staff here and for others to turn things quickly. So we know that things are not always as fast or as soon as that. We appreciate that.
While
Thank
we're talking
Yeah.
about that, just to level set everybody who's in this room and listening online, you know, having worked on this now for 4 or 5 years, it seems like 4 or 5 years, the numbers do change. The assumptions change based upon different interest rates. You know, the assumptions change based upon, you know, updates and healthcare costs that come through the SEBC. And as we get the latest data, there will be situations where a number you looked at a year ago or 6 months ago will change because the underlying assumption changed based upon either could be a legislative change, could be a cost change, could be, you know, the annual process that the pension board goes through to with Chiron to, you know, to reset the actuarial calculations based on interest rate assumptions and other assumptions. So we just need to be careful not to say, well, what you said a year ago or 6 months ago, sometimes these things.
Right.
Thank you, Secretary. So in the interest of moving forward, I believe we have Chris Giovanello from Willis Towers Watson that's joined us virtually this morning. Chris, do we have you on audio?
Hopefully, can you hear me?
We
Yes, we
can, loud
can.
and clear. Chris,
All
are
right.
you gonna walk through these slides? And did I introduce the correct team member?
I'll take us through the modeling slides. I think Jacqueline will take us through the first couple of slides. So we'll just be working together, but I think Jacqueline's on as well with audio. So
I am. Good morning.
Good morning. All right, we'll go ahead and we'll let you take over.
Wonderful. Thank you. So we've previously spent some time in prior subcommittee meetings talking about some of the similarities and differences between the state's employer-sponsored group Medicare supplement plan, MedicFill, and individual Medicare supplement plans that are available in the open market for individuals to purchase on their own. And so part of our discussion today as we talk about what modeling some of these Medicare supplement choice options could look like, we've taken a cue from some of these individual Medicare supplement plans as a starting point to sort of map out what some potential illustrative options could look like. So as a recap for the subcommittee, CMS requires that individual Medicare supplement plans, aka Medigap plans, offer standardized plan designs to make it easier for Medicare beneficiaries to shop for coverage and compare plans across different insurance carriers. And while it's not possible for the state or any other employer plan sponsor to contract directly with these individual Medigap plans, the state as a group plan sponsor could certainly offer a Medicare supplement plan option that mirrors one of the individual Medigap plans. And the state's done that already with MedicFill, which you can see from the chart we're showing here, most closely resembles Medigap Plan F. So for the purpose of comparison and to inform our discussion today, we've included a few other Medigap lettered plans that are meaningfully different in terms of the major plan design provisions listed here to, again, just help start the conversation around what some options could look like and certainly would inform, future modeling done on, Medicare supplement options. So Carol, could you please flip to the next slide? Thank you. So this is one illustrative example of what offering a choice of Medicare supplement plans could look like for the state. You could vary the plan design options that are offered based on different eligibility criteria and different levels of state subsidy. So Chris is going to talk about the subsidization piece when we get to the next slide. So what we're looking at here really just focuses on eligibility and plan design. Looking at the chart, and starting in the top dark yellow row, this scenario is saying that eligibility has been defined as two separate groups. So for a Medicare retiree who is hired or retired on, prior to January 1st of 2025, that retiree would be eligible for a Medicare supplement plan option that mirrors MedicFill. So, no different from today. For a Medicare retiree who is hired on or after January 1st of 2025, that retiree would be eligible for a choice of two Medicare supplement options, a high plan option that would mirror Medigap Plan N, and a low option that would mirror Medigap Plan L. And we've included the same kind of major design provisions in the chart below. In that scenario for that retiree, given the choice, you could vary the subsidy so that that retiree is required to pay more for the more expensive option. That would be the one mirroring Medigap N. So we haven't touched on prescription drug design, which we're going to address on the next page when we start talking about subsidization. But are there any questions so far on what we've reviewed here or on the prior page?
Keep going, I guess.
Lieutenant Governor, I do
There's a
it.
hand, Jeff.
Jacqueline, it's Jeff. Just to clarify, the second choice where we're looking at the choice between Medigap N and L, I think when you talked, you said that was for people hired after 1/1/25, but the slide says hired or retired.
The intention is, in this example, is hired or retired. So I apologize if I misspoke there, but here we're just focusing on hired or retired.
Thanks. I just wanted to clarify that. Appreciate it.
Sure. Of course.
Sorry, I think actually, I think the answer is, it depends on which of the three paths we take, A, B, or C, that either column can be used for any of those three. It depends how we want it modeled. It's available for any of those three.
Actuarially, the answer, we've been through this.
Mhm.
Actuarially, if you go with hired, very, very little impact. So we can model it all we want, but it's gonna show almost no impact. If you go with retired, it will show, I presume it will start to show an impact. I haven't modeled it, I don't know, but having gone through this with the Retirement Benefit Study Committee.
And that's why,
But Paul's correct, it could be either one.
and I thought that, and I was struggling with here because the way this is put up, where it says hired or retired for both of them, I don't know factually that actually works. Right?
Right, it's not that we'd implement it where if you're hired or fired, but rather we'd implement it one of those three ways.
One of the-
And that's one of the
Key it off on
decisions
hire,
we're gonna have to
yeah.
make.
One or the other.
Ultimately.
Yeah,
It could be one or the other, or something in between.
Hopefully you all can hear online. Can you hear okay? I have not been like making one person speak at one time. So if you begin to not be able to hear, please tell me. Okay, go ahead. Jacqueline, I guess.
Thank you. We can hear okay. All right. So then I think we're good to flip to the next slide, and I'm going to turn it over to Chris to talk about some of the modeling further.
Yeah, thanks, Jacqueline. So these slides should look pretty similar to slides that were previously presented to this committee. To Representative Bombach's question earlier, there are some differences. So when we looked at these out-of-pocket scenarios previously, they were individual marketplace analyses. So just to call out two of the key differences now, when we previously looked at slides similar to this, the premium contribution row, that was based on average premiums for these types of plans based on Delaware's footprint. So today we're modeling an illustrative subsidy scenario where, to Jacqueline's point, we're creating a buy-up from the low option plan L to the high option plan N. So the plan L contribution in these scenarios is based on 15% of the premium, the gross premium rate for that plan. So we were able to come up with gross premiums based on the relative value of these plan designs relative to the current Medicaid premium rates, if that makes sense. So for plan L, then we're taking 15% of that gross premium rate. That would be the modeled retiree contribution. That's the $682 that you'll see there in the first row. Then the plan N retiree contribution would just reflect the true then difference in premium between N and L on top of that $682. So that's where the $1,275 retiree premium for plan N comes into play. We've separately again modeled 10th, 50th, and 90th percentiles to show the impact on the out-of-pocket cost for retirees for each of these plan designs. To Jacqueline's point, though, for pharmacy, we're maintaining the existing prescription coverage under the current Medicaid plan. So we've not talked or addressed offering a different level of coverage for the prescription drug benefit. So in each of these models, it's assuming that the current prescription plan would remain in place. That's why you'll see that the pharmacy out-of-pocket cost is identical for each of the plans. When we previously met, the Medigap pharmacy coverage would have been based on Part D coverage. So that's why there's some differentiation there as well. So the first slide then we're looking at here, this is the 10th percentile utilizer, so low claims utilizer. Here you can see that the less rich plan L is a better benefit for those retirees with that choice based on their level of utilization. That's because the out-of-pocket cost is roughly the same at that lower utilization level, but the premium differential makes plan N much more expensive. So for those lower utilizers, they'd be better off selecting a plan L in this scenario. If we jump to slide 5, we have the 50th percentile scenario. So similar story, now we start to see a little bit more differentiation between the out-of-pocket costs. Again, the pharmacy out-of-pocket cost is still the same. It's a little bit higher than the 10th percentile scenario based on utilization, but we're not varying it across the different plans. So the premium contributions stay the same in this scenario. The out-of-pocket costs go up a little bit, and we start to see that spread. But even at the 50th percentile, you'll see a retiree would still be better off in plan L. And then if we jump to slide 6, now we have the 90th percentile scenario, so much higher claim utilizer, both in terms of medical and pharmacy coverage. Now you see it move the other direction. So now the differential in the out-of-pocket cost is greater than the differential in the premium contributions. So now for these higher utilizers, Plan N, the higher option would be the better benefit by about $500 for the total retiree cost there. So again, just taking a look at different utilizers, where they would be better off, whether selecting Plan N or Plan L, but this also highlights the advantage of choice. So some people are going to be better off in the higher option. Some people are going to be better off paying a lower premium for the less rich option. So having that choice would allow retirees to choose the Medigap plan that is better suited for their healthcare needs. And then these are all in, oh, sorry. I was just gonna say, these are all then in comparison to the current MedicFill plan design, which is the first column here, where again, the retiree premium contribution based on that 100% state share, either those retirees currently paying $0 or just paying that 5%, which would be the $276 premium, and then varying those out-of-pocket costs again based on that current MedicFill plan design. So I'll pause there and address any questions.
We have a couple questions here. I don't know if I have any online. Representative Bombach and then Representative O'Grady.
So Chris, 2 starting questions. You've got the slides. We've got them on the screen. We don't have them in front of us. I can't read those numbers. Can you give me the 3 numbers for the 10% and the 3 numbers for the 90% of the total retiree cost?
Sure. So right now we're looking at the 90th percentile. So for Plan N, it's 2207. For Plan L, it's $2,777.
And what's the MedicFill?
521 to 797.
Okay, and then the 10?
So on 10, the MedicFill is 198 to 474. Plan N is 1706. And Plan L is 1110.
Okay, now when I do back of the envelope, you say the 682 is 15% of the gross premium, which would indicate for Medigap L, the gross premium is around $4,550 per year. Okay, when I do the same, I see the 1275 is the delta between the N and the L. So if I add 1275 to the 4546, I get about 5,800. And if I do the 276 for MedicFill divided by 0.05, I get 5,500. That would imply that MedicFill is less expensive than it's more expensive than Medigap L, but provides a heck of a lot better. So my math is not working. Do you know what you said the gross premiums are for those 3 columns?
So yeah, so the gross premiums, I think your math is accurate. So for MedicFill, it is the 5,500. That is based on the current 2023 premium rate for MedicFill. So that's the $459.38 per retiree per month premium.
And that's from SEBC, right?
Correct. Yeah,
Yes.
That's the locked in rate. I think we have had separate conversations. We do know that premium rate is set higher than the cost for MedicFill. So I think that's part of your question. If we were to re-rate these plans, I think the MedicFill rate would come down, and then subsequently the L and the N premiums would come down as well. But the true premium rate we have to go off of in this scenario is the current MedicFill premium rate, which is $5,500. And then the Plan N gross premium rate would be $5,100, and then L would be $4,500, to your point.
Thank you.
If the way we've set L and N is relative based on the plan design differential to the MedicFill premium. So if we were to re-rate MedicFill, I think the true cost for MedicFill is closer to $5,000 per retiree. Everything would come down accordingly.
Thank you.
Thank you.
Sure.
Representative O'Grady.
Just one quick question, Chris. In this modeling, you used a 15% contribution rate by retirees, correct?
That's correct.
Where did that come from?
I think that just came from, or sorry, I think that was Faye.
Oh, Chris, I was going to say, that was what we requested for the purposes of
Okay,
discussion.
all right.
We used 15 because we used 15 in some of the other options. Yeah.
Gotcha. Okay, thanks.
Great to have that. Very good. Anyone else? Questions online with anyone?
I'd like to thank WTW for getting the 10 and the 90th so quickly.
Yeah, that was a quick turnaround. We really appreciate having that movement turnaround. Appreciate that.
Lieutenant Governor, I do have
Yes.
one or two
Good,
questions.
Jeff? Yes.
So, it's Jeff again, just want to make sure for clarity, if we were to move to this proposal, is this taking us out of being self-insured like we currently are under the medic fill and moving us into a situation where coverage is being provided through a carrier provided plan, or will we still be self-insured? Or is there an option of doing it either way?
These scenarios are all based on remaining self-funded, similar to how the state offers the medic fill plan today, which mirrors Plan F. We would be offering 2 additional Medicare supplement plans that just mirror other individual market Medigap plans, but no change to the self-funded status of the GHIP in these examples.
So I'm going to continue to ask the question I've asked several times, and I realized between last meeting and this meeting, I was probably asking the question the wrong way, because I was asking, could we issue an RFP to see if somebody could provide the medic fill level coverage through a commercially provided plan? And based on a number of things we've heard from the public about them going out in the marketplace. And I think Brian correctly answered that from a cost standpoint, that wouldn't be effective. So the question I'm now asking is, since we're offering a choice between Medigap plans, is it possible to do this through an employer-sponsored plan where you would be purchasing coverage from a provider as opposed to being self-insured, which would limit your exposure, because as a self-insured, you're on the hook for all the claims, as opposed to them issuing you a policy based on your pool where they're assuming some of the risk to provide that. I just want to know what's
Right.
possible.
Any thoughts from your side, Chris? I know this has been an ongoing discussion, right?
Right.
Between the.
And again, I realized based on a number of comments last week and looking at it from options of Medigap as opposed to just something that is equivalent to the current Medic fill, that there could be a different answer to the question based on the way it was changed.
Jacqueline, are you?
Chris or Jacqueline's fee. I mean, I know we've had some preliminary discussions about this. I hesitate to affirmatively respond to Jeff's question, but I believe we've said that it is possible we could structure a request for proposal that asks for both self-insured administrative rates for Medicare supplement plans, as well as fully insured premiums for those same Medicare supplement plans. Is that correct, or your understanding of our conversations?
Yeah, Faith, that is correct. We can't guarantee that the fully insured quotes will be as financially advantageous upfront for the state as a self-funded quote would be, because carriers typically include loads in the premiums for fully insured plans. But you could certainly structure an RFP that way to ask for fully insured quotes on a Medicare supplement plan as well.
Thank you.
And then I know here you've done this model based on going from providing L and buying up to N. Could we also at some point be provided information on providing N and buying up to G, or providing L with the option to buy up to N or G? Right, because I know when we look at the coverages in Medigap, if I understand correctly, from most robust to less or least robust, they go G, N, and L. And what we have here is the middle and the low. But before making a decision, I for one would like to be look at all the options.
One of the things I think we've heard a few times, and maybe you can talk to about it, is that G is quote unquote going away.
G's here, it's F that's going
Oh,
on.
yeah, I'm sorry, okay, sorry.
Yeah. No, that's why I didn't
Professor,
include
you are
that.
all today.
That's why I didn't include that.
Your
Okay,
alphabet.
fine, I just want, sorry, I know,
No.
want everyone to know that it's not that.
Somebody's ready either way.
And Chris, to Jeff's question there, we did look at G. My recollection is really the only material difference between E and F is the deductible, which really we didn't feel from a cost reduction standpoint was really going to
But
be
it's also the
material.
out of country deductible. I don't even think it
I
was a
can't-
straight deductible. I think it was if you're out of the country. It's like a $280 per year thing.
But it's 288.
288, yeah.
Jacqueline or Chris, I don't know if you could
Answer
speak to
that.
that deductible for G.
I'm sorry, can
Yeah.
you repeat the question? Oh, go ahead.
Yeah, sorry, I was gonna say, so F and G, the difference is really that Part B deductible. G and N, the only differences are really some copays for the Part B services. So G and N are very close together from an actuarial value perspective. I think the difference is like 4%. So I think we modeled N instead of G here just to have a little bit more retiree skin in the game in terms of how they utilize care. G and N again would be very close though from an out-of-pocket perspective if we were to look at G instead of N. And then the goal here was just to create a meaningful differential between the two choices. So that's why we landed on L as the lower option. So we can structure this any which way. We could offer G and L, we could offer, any combination and we can model it however the committee would like to see it. I think the goal here was to make sure retirees had some skin in the game and that also we had that meaningful differential between the two plan options that were offered.
And what I'm gonna say is not intended in any way to be disrespectful for anybody, but I would, as a member of the subcommittee, prefer to be able to see all the
Yes.
modeling rather than rely on the representation. So I'm looking for not only what you gave us, but provide N, buy up to G. And I'm also looking provide L with the option to buy up to either N or G. So to provide as much choice as possible within the Medigap and supplemental field.
So did you all understand that? So if you could model the G up to, that would be preferable, just so we have a full slate in front of us when we make recommendations. As a reminder, we're talking about SEBC. Again, we are a recommending body. Every now and then I start with that, the Senate Bill 29. So our recommendations will go to the SEBC. And for Representative Wagner, thank you for joining us. We're talking about future
I'm with you.
hires, gotcha. So we're not affecting you. I had to call her out. It's so nice when I see former colleagues.
Lieutenant Governor, if I may, can I repeat what I think I just heard Jeff request so that we're all aligned on what the ask is here? And then I have a question as it relates to modeling from Margaret, recognizing, as we're all aware, we're doing these meetings about 10 days apart. And I want to set expectations on what can be done for the next meeting, which I believe is August 10th. So what I heard Jeff say was, could we look for proposals? Could we model F? Wait. Sorry. Looking for N, buy up to G.
Correct.
Provide L with option to buy up to either N or G.
Correct.
Okay, sorry, I had too many notes there. I was reading it online.
All
right.
And to put numbers, because I love numbers, as I understand it, as presented, you've got roughly a 15% retiree share for L based on the premium you're assuming. It works out about a 25% share for N. And then if you have, say, a 30% share for G, that lets you step up from the least generous to the more generous in a sort of linear way. And that's one way to do it. You in your footnote describe how you went from N to L or L to N, maybe something along those lines, just to keep exactly what you're going to do. I'm just throwing numbers out there so that we can start with them and then we can adjust.
Okay, I'm gonna let Chris respond to that one because I have to admit, Representative, I'm a little less clear on what you just said.
He wants his numbers. Chris, did you understand Representative Bombach?
Yeah, I understood. So, we will consistently set the lower plan option at the 15% rate. I think G, to Representative Bombach's point, will naturally be about 30% if we do it that way, but we'll make sure that it aligns. But keeping the same methodology, I think, gets to the scenario that Representative Bombach was outlining for Plan G.
Thank you. And again, we recognize the turnaround time. Appreciate that very much. Lieutenant Governor, before we move on, if you don't mind, may I, we should have Margaret on the line. I believe if I'm tracking with the asks here, that's 3 different potential models. Chris, keep me honest here, because you're the actuary and you will, and Margaret, but we also need to include the medic bill plan design for the current retirees in each of these models. So I'm trying to get my head around how many different models we are potentially running for the next meeting on August 10th. And can that be done by Margaret by August 10th?
I think you just have one additional model. As I understand it, you are modeling medic fill or essentially medic fill, whatever, for current retirees. And you also, for future retirees at A, B, or C, maybe we choose C for the modeling purposes, we just need a distribution saying that 50% choose L and 30% choose N and 20% choose G. That's just one model. You just need to have them across that, right? It's one modeling.
I think that's an
exercise.
approach, but that's again where I feel like we don't have
She
clarity
needs
for the
clarity
actuaries to
for
move
that.
forward for the next meeting. So perhaps it requires a little more discussion because we're still not clear on, are we doing model B, right, or model C? And then there's some assumptions, I think, about the percentage of future retirees that would go into these other plans.
So I'll restate my request first, and then others can build upon it. What I'm interested here, we're just looking at one movement, which is from the lowest level of gap coverage to the middle level of gap coverage based on what is defined by CMS standards. I'm interested in exploring, in addition to what has been explored already, similar data for base plan being N with the ability to buy up to G, and then base plan being L with the ability to buy up to N or G, so that we have the same information. I believe the good representative, and by the way, my representative, has some refinement on that, and I'll let him state
Take
that.
next.
Can
So
I
are you with?
add one thing that might simplify this?
Yes.
And I was gonna talk about this later, but I'll bring it up now. We have to stop modeling things that we already know aren't going to, we can model things till the cows come home on, only people who are hired after 225. But we already know the answer. They don't move the needle, and then we sit in these meetings and people go, well, why would we do that policy? It doesn't move the needle. And they're exactly right. What I would suggest we only model, and it will make the life of the actuary simple, is just these models that say, if you retire after 1/1/2025. And then we can work backwards from there. If we want to work backwards from there, let's see what that does. And then if people say, well, that overachieves our goal, we can always say, well, let's, make it based upon, people who didn't have 10 years of service or 15 years of service or whatever, but continuing to model a higher date is it's not going to achieve anything. It doesn't move any of these numbers, and we've shown it over and over again in these models, and it's a tremendous drain of time on the part of the actuaries to do that modeling, because we already know the answer is no impact.
So I'll couple of things. I don't disagree. It doesn't move the needle. And I know based on what the actuaries have told us, what does move the needle are the funding.
Funding. Refunded the
But
money.
we've talked about plan design and other things as part of this conversation. And I think it's incredibly important that we address what future retirees are going to be offered by the state. So for me, I need to know this whole idea of choices between gap coverage is something that, quite frankly, hit me after the last meeting. I heard.
I want her to model that. What I don't want to do is model one that says only if you're hired after.
Well, and
2025,
what I'm-
because that model will show.
That's an entirely different-
Okay, gentlemen, I'll have to get my bag. or get my
But it's
bag.
important because if we're
One
gonna
at a time.
have them model those two things, and then they've got to turn that into 3 other models based upon when you get hired and when you get aged, it's a multiplier.
And maybe what I was doing, Rick, was looking at this incrementally, because to me, the way to do this is get the base information on what it looks like, and then have the conversation about who's in and who's out. What is the definition of a current retiree versus a future retiree? And what is the conversation about hire dates and retirement dates? Until I know the base information of what these plans do and offer us, I can't tell you where my head is on, should it be somebody that is hired after the 1st of January 2025, or should it be somebody that retires after that? Because I don't know what the impact of the plan is, and that's why I was looking at it. Get this information, step one. Step two is then figure out where are you going to define the populations, knowing that we've generally committed and agreed that current retirees should stay in the medic film. And what honestly, after the last meeting for me really hit, based upon Ms. Allen's comments and then a number of the follow-ups and considering, is Medicare Advantage as an option doesn't move the needle for me anymore, and our board's taken a position that that should not be considered as an option. So,
But at the end of the day, what I'm hearing, I think Representative Beverly didn't need to cut people off conversation, and out of respect to our secretary, certainly understand secretary, but I think Professor Gutenberger, you have a different level of understanding and knowledge than most of the people on the committee. And I think for them to have a basic baseline, and I recognize it's a lot for the actuaries, I feel that for them, at least to have that baseline with both the comparison of the hire and the retire date. And
I
I'm
think
sure
you've
this
asked for
is,
2 scenarios. It actually requires, they're gonna have to do 6 different models now.
Thank you. That's kind of.
That's what's gonna
And
happen.
so-
if they're doing the
what do
higher
you
date
think?
now, or if they bring back the information and then based on what we see, we ask for higher dates, that may mean that be narrowed down to fewer selections, right? Because we're trying to do it all at once, that we're creating more work rather than doing step one, looking at that, thinking about it, and then making a decision on step two, which may or may not narrow down the work.
I agree. I would reinforce both their points. Frankly, having everything with choice C, because we have some only with choice C, which is the retirement date. So that we have apples. With that, we can roll stuff out and then say, okay, we're down to these 3. Now, these we would like to see higher date after 2014. But we don't want all 3 for everything we're looking at. We've got maybe 2 things, new things we want to look at. Let's just look at one scenario to Secretary Geisenberger's, fine, retire 2025 or after, because that gives us an apples for all. I've got like 10 choices already without the stuff we added today.
so how do we?
Well, it's
get
kind of like,
where
let's
you
see what
are?
it does.
Yeah,
If it
absolutely.
overachieves, which it might, I don't know.
Yeah.
You can.
I think we're fine running one scenario for each model.
So how
Model one
many
scenario, which
would
is
you
the 2025 retirement or later.
But that's, I'm looking at Facebook.
B,
What is it? B?
No, it's C.
is that option C or option?
It's C.
Which one's C?
I mean, it would help you
Retired.
phone in on the
January
versus
25 or
versus
later.
whatever.
Those
And then-
online,
and then
are you
from there,
following
you
us?
just go back.
Margaret has her hand up. Margaret, why don't we hear from Margaret, because she's doing a lot of the work. Margaret,
Retired.
It is C.
can we unmute
That's
Margaret?
what I typed, but then. Should
Yeah.
be able to unmute herself.
There you go,
Okay.
Margaret.
I'm off mute, but in terms of determining the population distribution between who chooses N or L, it doesn't much matter. I will model L because everything else is a buy-up. So basically the retirees are paying for the additional benefits. So don't worry about the distribution. I'll just end up modeling the lowest planned option as long as it's a true buy-up where the delta between the costs that is the retiree pay. So it doesn't change the liability.
Is that feasible, and does that meet your request, the secretary, all of your requests
I
here?
think that's the way to model it, because we'll then come back to say, I know what will happen in this committee. We'll then say, well, what if some people only have to pay 25% of the buy-up and some people only have to pay 50% of the buy-up? And I think that's a good conversation to have, but the first thing is model it in sort of the, I mean, I hate to call it this, but the pure way, see what impact it has. And then from there, say what variables of it you'd like to say. I think that's the easy.
Margaret, did you hear that in Willens Towers, so they understood? Or we have overly, I know you look like you're in pain or thinking.
Yeah, I've got to maintain. You know. I guess I come back to a comment I made earlier that, you know, my concern is around impacting current employees. You know, I've always looked at this as prospective in terms of new hires, whatever that date might be, whether it moves the needle too much or not enough. The concern I have, and I use the term, we have a moral contract, that employees came on board, state employment, and they were said, this is what you're going to get when you retire. And I basically have a problem of violating that trust. So, you know, we can model all we want, but at the end of the day, I just want to be very clear where I'm at when it comes to impact current employees. So
And these current employees, and for those who are retired,
you're not impacted.
you're not impacted because you're grandfathered. Let's clarify that part too. And we'll have
I
public
just wanna
comment
be
later,
very
we'll have an opportunity
transparent.
later at the end.
Where I'm at.
And I'm gonna be very transparent, which is, we have 18-year-olds that I just hired last week. So if we say to them, this is a benefit you're gonna get when you turn 65 in 50 years. And that you'll have for another 60, you know, till you're 70, 80, 85, and we make no change in it. Then everyone in this room needs to understand we made a decision to not reduce the OPEB liability. We will grow the OPEB liability, because if you make a 70-year promise, which is what you're doing to a lot of new employees, and I got a lot of people who work for me in their 20s and 30s. That is a very long-term commitment to make to them forever, for the rest of their lives. It will not reduce the liability. Now, if that's not our goal, then, you know, we're going to talk about that later in this meeting, which is how that impacts the budget.
And when it's quarter of 11, I mean, and the thing is, we've been focused on design, some of that's eligibility, but I understand what Representative Overly is getting at, because we all worry about recruitment, retention, and all those.
If I might just respond,
Yeah.
and I appreciate everything Secretary Geisenberger says. We may not agree all the time, but quite honestly.
We've had these kind of discussions for
Well, we
25
have,
years.
we have.
It's all friendly.
It's all friendly, and I have a great deal of respect for Secretary Geisenberg, but I read through Senate Bill 29 the other day. It not once does it mention OPEB liabilities. It does say evaluate options for continuing to provide strong state retiree healthcare benefits in a fiscally sustainable way, which you could.
Exactly.
Which is the
believe
OPEB
that
liability.
Right. I
OPEB
highlighted the
liability.
same words.
Our OPEB liability problem is a funding issue.
It is, and that's why we've come up with the proposals, Dave and I and others are looking
Yeah,
at.
and you know, we've asked that we look at different modeling aspects for percentage of payroll over and above the 1% carve out. That's where I'd like to focus. If you're going to get the bang for your buck, that's where you get it in terms of OPEB liability. Not backing out of what I consider to be a commitment to state employees. So, you know, it's just my personal.
Good, thank you. Thank you. So anybody online, questions or comments? If not, we'll move on. It's 10 of 11. So I know we've got a few more slides. Faith, you want to take us away on next items?
I think perhaps, unless Margaret or Chris have any objection, we're gonna move off of this discussion. I think pivot over to the other slide deck, which is largely the same as what the subcommittee members have seen. We've been building off the same deck, adding a couple of slides each time we meet. So perhaps in the interest of time, if the subcommittee is in agreement, we could jump straight to slide 10, I believe. No, slide 11. Slide 11 would be the first new slide for today's discussion. And Lieutenant Governor, similarly to the last discussion, I think we're going to do this together as a team. Obviously, Margaret has modeled a couple of things at the request of the subcommittee members from the last meeting. The first slide, slide 11, I believe was a request from the Lieutenant Governor.
And me and Dave Craig, we knew that we were looking at something, you know, that would have obviously probably a fiscal impact on the general budget, but we also recognize that we need to have a commitment. And Dave, I don't know if you want to comment. We certainly recognize that this could be spread out even over a 20, we had originally said even 30, but then we heard from Margaret and Joanna that it's easier with 20. We also discussed how we could have a lesser long-term liability impact if you did do it to 8.5%, but it is a mechanism for pre-funding based on OPEB, which is very similar to the PRI, the pension retirement account. Dave, do you want to add on to that, what our thinking was?
Page 11 is the same as we had last week. It's not the new.
I apologize.
She was on
a little
vacation.
out of pocket for a couple of the meetings, and you're right, I'm looking at the top. So this is not a new slide, right?
No, it's
So
not.
you're looking at, as the Lieutenant Governor says, at the 0.5, which I think page 12 does in a different format.
Right.
Page 11.
And our guesstimate stage was what around, it was probably, we were guesstimating what around, if you did the 20%, it would be like 20 million or so initially, and then going down after 10 years to 4 million. And then if you did the other, it'd be like 10 million, and we were guessing.
Yeah, so
Yes.
page 7 showed us a little bit just going from the 0.36 as it was. But then page 12, I'm assuming incorporates within all these different options, the 0.5.
So again, this isn't in addition, so the legs of the stool, right? You got your funding. We know that the General Assembly has passed Senate Bill 175. Thank you to Senator Townsend, Senator Penny John, Representative Nunn, Representative Bombach, who are here, and I'm probably missing somebody else. Have gotten that to the governor's desk. I don't think he has signed. He did sign it. He did earlier this week. Can't keep up with all the bills. So Senate Bill 175 was signed. So we know that that is separate. That is the 1%, but this is an additional component.
That's 1% of budget. This is
Yes.
percent of payroll.
Yeah, payroll pre-fund, OPEB. So it's parallel to what we do with pensioners. And it really does provide a mechanism to dig ourselves out of the hole. What you have to acknowledge is, again, it would impact some of the general fund monies that are available for other expenditures in the budget. But, Dave, I know we don't have the actual full cost here from Joanna laid out. I don't see the cost. I think they were estimating like 20 million a year initially, if you did the 1% over 10, and then it was like 10 million. But again, we'd have to have those numbers laid out, unless my eyes are bad.
It's around 25 million new each year.
Okay, if we did the 10 years,
That's
did the
about right.
kind of, if you did it more intense draconian.
Payroll's about 2.5.
Yeah, if you did the more intense over 10 years, but if you spread it out even over 20, I think that is probably a more palatable.
0.5 should be 12.5 million
Okay.
per year.
Yeah, and can you explain to the group too, because your finance probably better than me as the health professor. I do health accounting, but this will also impact our rate of return with assets. So while we're doing this,
Yeah.
can you explain that?
Yeah, the whole thing we haven't really discussed is we have the trust fund.
Yeah.
600 or $700 million in the OPEB trust fund right now. So we're assuming a lower discount rate, but at some point, hopefully we can use the pension rate because it's commingled with the pension assets for investment purposes. So that's 7% of the pension rate. So it never comes in at 7, it's always above or below.
Yeah, even if you think of 5% or something, like a worst case scenario.
Fortunately for the pension fund, since we started as in 76, I would say our long-term returns are probably a little bit higher than our assumed rate. So that would help out.
Right.
If we are exceeding our assumed rate, help out these contributions, the payroll contributions that would be required. And right now the pension rate goes up and down based on a lot of things, but one of them is the investment returns.
And I know in the, Rick will show slides too, where it's like pay go, and you put all those factors, but I think, literally in the bonding rating agencies, certainly if they see that you have this solid plan that includes design change along with funding, and it's realistic. I mean, it's an option to really consider.
Back in the 90s, the pension rate was actually got below 2%. Because of the investment returns, all the tech stocks and so forth. So we put in language that if it got below 2%, then the difference would go into the OPEB trust. And then the tech bubble burst and it went above 2%, has never been close to 2% since. So, we identified that these investment returns were having a huge impact on funding, and we tried to divert some to OPEB, but it didn't work out like.
But again, thank you. Like I said, Dave and I had talked and, we know that this is not perfect if it's over 10 years, but this is something up for discussion, pre-fund, even if it's 20, could be having a positive impact. And again, Senate Bill 29 was vague enough to allow us to at least provide recommendations, because what we will do at the end is make recommendations, to the members of the General Assembly and to the governor, such that these do have implications for retiree health into the future and current employees. So I don't know if there's any other conversation with this slide. If not, we can move on to the other new slides. Yes, Jeff.
You're gonna regret me being here in person.
No, no.
So, again, after last week, listening to people or the July 10th meeting, here's the question I have. We do have the base of the 0.3%. We now have the base of Senate Bill 175, which gets us the combined 2052 funding rate of 59.8%.
Right.
So rather than making the assumptions of where we're going to take the additional payroll tax, I'd like to do it the opposite way. If our goal was to get to a 2052 funding rate, say of 70, 75, or 80%,
Right.
what would we need from
This
increased payroll tax on top of the 0.36 and the result of Senate Bill 175 to get us there?
Can we do the next two slides before we have this discussion? Because I think they're relevant to this discussion.
That's fine to me.
Look at them, but go ahead.
But doesn't page 12 answer your question? We get to 80%.
We get to 80.
That's with everything.
Yeah.
It gets to 80.
That includes all of them. right?
Yes.
Okay, that's interesting.
And that's still taking it up to 10%, isn't it, Dave?
Yeah.
And that's
And I
10%
guess the question
over
I have
10
is-
years, so we could say, what would you, if it was a 0.5%, so Margaret, if she's listening, or Margaret saying 0.5 over 20 years, I hear what you're saying, like, what would
Do
it
we
take?
have to get to 10% in order to
No.
achieve an 80%
Yeah,
funded
Jeff
rate?
and I've had
Yeah.
this conversation.
Or is that just, that was something that was here because that was the straw man or straw?
Right, because we
person,
just,
whatever.
Dave and I threw something out, but I hear what you're
Right.
saying with Margaret, and then perhaps as we look, and after, I know our secretary wants to do.
And again, I would go back to the earlier slide, which is page 7, where we simply went up to 1%. According to this, that achieves another 7.7% in terms of improving our 2052 funded ratio, which leads me to believe that we don't have to go much beyond 2% for the increase in payroll tax, not up to 10% when you combine it
Right.
with the base from 175. That's my assumption. And that's what I'm asking. Can somebody run it? So not that this is what we want to go up to, where does it get us? But if our target is 70, 75, 80,
Right.
knowing the base, which is the 0.36 plus the outcome of 175, what would we need to do to get to our goal?
Right. And Dave, what do you think? Because I mean, you and I kind of came up with this, we kind of.
Yeah, my issue was with that is we're going a little, some of these things backwards is, well, let's settle on the plan design for the retirees after 1/1/25. And that would really get us into a number that should be fairly close. Looking for what Jeff's looking for. We don't need the deep 10% because we've done this plan design, which is going to save money on the payroll side.
But it would be good to have something in the pre-funded and that funding stool leg, in addition to the 1%.
And if we know just based on what's 175 and the pre-funding to get the 80% is X, and then we get the information David has, we may be able to reduce what we're going
Yeah.
to do in terms of here to still get to that goal. But now we're getting pieces of a plan
Right.
that can come together to get us to the final end.
I mean, that's all been our goal all along, right? To have a couple of different options of what's best practice, what could be good for future retirees. And we know current retirees, we're recommending either the grandfathering.
We've danced around this one question for 5 months now. What is our target level? Is it
That's why I
70?
threw out 75, 80.
Right,
All right.
we actually, in the Retirement Benefit Study Committee, and I think we talked about this at our first meeting. We actually did come up with some specific targets. Mary Graham, I think, wrote us all a letter, I think last night, saying we all ought to figure out what our target is. I would suggest we start with what the RBSC came up with, which was that It said by 2050, but of course that was 2 years ago. So let's make it 2053, 30
Yeah.
years. A target of 85% funded ratio.
So it's kind of. what we were
And,
saying.
and over a 10-year period, reach a 35% actuarial funded ratio and be able to contribute 100% of the actuarially defined contribution. Because that is how the pension fund got to where it was. It eventually got to the point where the contributions equaled what the actuarially
Mhm.
defined, actuarially required contribution was every single year. I mean, the pension fund probably started that at the beginning of time or maybe.
1976.
So even at the beginning, so it took 6 years to even do that, right? But so those were the objectives. I'm pretty confident that if we can do that, that, you know, that's a reasonable time frame within which the, you know, the rating agencies that look at this would say, yeah, that's a reasonable financial plan. Now, as you know, because you were on it, the Retirement Benefits Study Committee also recommended that we should get there half through funding and half through benefit changes. Benefit changes can be design and or eligibility. It could be just eligibility, it could be just design, it could be a combination of the two. And we can move away from that and say it all ought to be funding. But I think the next slides are important to look at when you start to say only funding ratios. The other thing I wanted to comment on, because I missed the OEC discussion, is did you discuss the special fund issues?
Right, we did a little bit about the pre-fund and some of it.
Yeah. I mean, there are a lot of agencies right now that are already choking on their OEC rate. And those agencies are predominantly special funded agencies. DENREC is a great example, but agencies that rely on fees that they can't raise without the General Assembly increasing those fees to fund their personnel costs. One of the reasons why the Retirement Benefit Study Committee recommended that we use 1% of the general fund budget as our mechanism, as opposed to relying on OECs, was the recognition that by relying on the general fund budget, you wouldn't have to worry about that fee problem that so many agencies are choking on right now with their existing OECs. So I'm pretty confident that if you put on automatic pilot, that OEC rate is going to go from a relatively small number of 0.36 to 10% over
Right.
some period of time. General Assembly better be prepared to raise fees.
Right, well, we talked about
And that's
it,
why-
knowing it was draconian, that's why I think he's
That's
saying.
why I asked, you know, because when we
Look
looked
at
at
it,
this was just done based solely on OECs. There was no current 0.36, there was no outcome of Senate Bill 175. And while the information we got on July 10th was helpful, well, I wouldn't say that. It gave us an idea of what the impact was. It really wasn't helpful because it was doing it all based on OECs. And it wasn't realistic. So as I thought about this more, it's like, what's the base we have? And what do we need to build? And I would say also, Secretary, everything you said about the Benefits Subcommittee that Mike and I sat on with you was correct. But I also think here today, we have a lot more in-depth and detail regarding the impact of plan design changes and eligibility changes, which has led me to realize in terms of OPEB funding, you achieve very little effect through those means. Where,
You have
as
to-
Margaret said before, the way to really take care of it is through funding. And we didn't have that back then. So
No.
that's
You would have to.
additional information.
Because this group has said we're going to take all current retirees off the table. But even then, there are things you can achieve pretty well if you pick a retirement date. You are correct, though. Any scenario that says if you're an active employee age 18, none of this applies to you ever. You're correct. None of those are going to move the needle. But you can move the needle if you say 1/1/2025 or 1/1/2026. And I think Margaret's models will show that. So they won't move it as effectively as some other things, but it's a piece of it. If you rely exclusively on funding, that's where the next slide is important,
Right.
because it also means you've made a decision. We can go to the next slide.
Yeah, we'll go to the next, before we do, I have two hands were up, Denise's and Denise, go ahead.
I'm trying to better understand and help me, we talk about the funding and we talk about these three-prong approach, but one of the things is, and I don't know who was speaking before about the plan design, that don't we need that plan design to figure out how the funding falls in and with that and then the eligibility, but we keep missing that piece of the plan design that I just don't understand why we're not there, where how can we do the funding if we don't have a design?
But I think, form does follow function, right? Like Lloyd Wright says. And I think what we're doing here is a combo, and I'm sure it seems confusing. You have to have, you're right, design piece, but I think we too at this table, I know Senate Bill 29 is not all about OPEB liability. I think some of us maybe leaned in a little bit to looking at that long-term liability, but to the retirees here and in the hat you're wearing on this commission, I can understand why you're like, let's do design. So I think this is a nice transitional actual conversation, because I think our secretary is going to mention about how funding alone will do it, and you need to look at design.
I agree that design and eligibility are something, and this is why, because so what this chart does is it just says, let's look at no additional trust fund contributions. What is happening? Okay, so the blue, what you see is showing that retiree healthcare costs, this includes both pre-Medicare and people on Medicare, that the net cost, this is after you get premiums from those retirees that are paying 5%, or for those pre-Medicare people who might be in the PPO plan, they're paying 13.25. It includes the drug rebates coming back, but after that, there's a net cost to the state. Okay, so that net cost rides up from 250 million to close to $1 billion over that 30-year period. We then did an actuarial calculation, look at the last average growth of the budget over the last 10 years, which is around 3.7%, something like that. You could change that assumption to 4% or 4.5%. But the reality is that that's been a pretty consistent number over decades. What percentage of the budget is consumed by this cost? Now, this excludes any additional, this excludes the 0.36, this excludes the 1%. So the 0.36 equals about 0.16% of the budget. The 0.36% of payroll is about 0.16% of the budget. 1% of the budget is obviously 1%. So you'd have to add 1.16% to all these to this chart. But what it shows is that retiree healthcare goes from consuming a little bit over about 5.4% of the state's budget, and will rise to 7.4%. So that's 2% more of the budget being consumed by the cost of retiree healthcare. If you decide, and we've already agreed in this committee, I guess, to do 0.36 and another 1%. So it actually is going to go from about 6.4%, where it is today, if you include the 1% we did this year, to about 8.4% over this time period. It says particularly steep rise over the next decade, in part because of baby boomers and some of the actuarial assumptions that also go into the rate of growth of healthcare costs, in part also driven by population and demographics, that then begins to layer off, unfortunately, as some older people pass away and as the demographics change. But that is sort of the core of the problem, is that are we committed to consuming, and this, by the way, doesn't include, and Claire, Secretary DeMattis asked me to point this out, this doesn't include active employees at all. So while retirees are going to consume 2% more of the budget in healthcare costs, in addition, active employees are also consuming whatever the number is. I haven't done that calculation. That's more of an SEBC thing to do. But that is the challenge that we've got if you don't make design or eligibility changes. And it's not, I realize we can just sit here and say, well, let's fund it more,
And I'm not.
but it's not going to fix
I'm
that
not just saying
problem.
furthermore, what are the assumptions for increase in medical and RX over the period,
Margaret,
the average rate of increase, and then I'm going to yield to Representative Overly after that, because I know cost is a concern of shares.
So we have several hands up. We have,
Margaret
also,
can answer that question.
Margaret, if you could
Because
answer.
these are all based on Chiron
Um,
actuary.
So I have several hands up, and in order of due process, so everyone gets a chance to speak. We've had a question posed for Jeff that Margaret will answer. We have then a request for Mr. Representative Overly. Then I've seen Mr. Wayne Emsley's hand, and then I have also seen David Craig's, and I have seen Representative Bombach in that order. So I want to make sure everybody gets a chance to talk. So Margaret, did you hear Jeff's question? And if not, Margaret, we can repeat.
Yes, I'm just looking it up right now because
All right, while you're looking that up, if Representative Overly just yours tag team with what Jeff says, because if not, I might go to the next person.
Well, my discussion, yeah, my good friend Jeff.
We're good friends too, we put each other on
Yeah,
the spot.
absolutely. No, I don't dispute these numbers at all. In fact, I've been focused on the pay-go problem we've had in the state and have concluded that we've got a pricing problem predominantly within the healthcare sector in the state of Delaware. And that's been quantified by RAND, through the Insurance Commissioner's Office. It's been quantified through Johns Hopkins study. Even Willis Towers Watson has presented us with data on the SEBC subcommittee meetings and to the SEBC about the pricing disparities between hospital-owned organizations and freestanding facilities. Now, that's being exacerbated because the hospitals are now buying up freestanding facilities. So I don't want to get into a large discussion about this. Faith has been very good in trying to wrestle with it. We've done some creative things like carve-outs through Surgery Plus to reduce the pricing problem we have in this state. But it's a larger conversation that maybe another committee needs to have.
And some-
But you know, none of the things you.
Representative Overly is speaking, please.
A broader discussion around, how we control the pricing disparities that are taking place within the state of Delaware. I didn't make these numbers up. You can go back, it's all public information in terms of the pricing disparities. But Jeff and I actually met with the CEO of Christiana Care. How many years ago, Jeff? 3, 4,
Probably 6 or 7 that you all
6 or
did that.
7, yeah. Who swore to us they would not buy up independent freestanding facilities. Well, they continue to do so geometrically. And you can walk into an urgent care facility today where you would have paid 20% of what you pay in an emergency room, and you find out it's owned by a hospital now, and you got an 80% higher bill. So there are a larger discussion to be had in terms of pay-go, which in fact are driving the overhead liability that I think you need to have. And as I said, Faith and SBO, I mean, she's been so overwhelmed over the last year and a half with getting hit with everything. But there's this discussion to be had around TPAs and how they manage what they do for the state of Delaware. So, there's a much larger issue at play here, just beyond looking at the numbers. I don't disagree. There is that growth in healthcare expenditures, and it's going to continue unless we begin to deal with the genesis of the problem, and that's pricing. So
Thank you
I
for
read my
that.
case.
You read your case and going in the order. We have Margaret, if you've got the answer, feel free to speak. Go ahead, your hand is up, and then we'll go to Wayne, Dave, and Paul. Go ahead.
Okay.
Margaret.
So the non-Medicare medical trends are 8% trending down to 4% over a 20-year period. And then the Medicare side is 6% trending down to 4% over 20 years. And the drug overall for all groups is 8% trending down to 4% over 20 years.
Thank you for that. Okay, Mr. Wayne Emsley, you're next.
Thank you. I don't doubt your numbers, but I am very uncomfortable with the distortion that this graph provides. In the sense that particularly the right-hand scale starts at 5% and ends at 7.5%. And to me, that heavily distorts the impact we're looking at a percent of budget changing less, and I'm sorry, yes, changing less than 2% over 30 years. And I'm very disappointed that this graph is so distorted in the presentation.
I think I was very clear.
Right, can we go in order?
My co-chair is becoming the parliamentarian today. It's good. Yeah, we know. But we'll have a moment, so we'll put Rick on, we'll give you a chance to speak after. How's that? Okay, Dave.
Well, I have a question for Rick, so I'm not sure if I'm allowed to ask, but I'll ask.
You're allowed to ask. I don't.
Yes, you're reversed, yeah.
So I guess just so we all realize what could happen, worst case scenario. So in 2023, I'll just say that's $250 million. And in 7 years, we're up to $400 million. So revenues are flat. What happens to this $150 million? How do we get that funds to pay the pay costs?
Well, just, can I answer?
Yep, yes, you can speak now.
This doesn't try to forecast revenue. Whether the revenue is going to be available for any of this, who knows?
But I think we all need to understand.
Right. Well, the answer is that we won't give pay raises. We won't give, I mean, those are the, that's how the budget works. Either we won't give pay raises, or there will be personal income tax increases, or there will be gross receipts tax increases, or there'll be some sort of tax increase to cover it. Because if you don't address these things, then, you got to pay it. Right? It is what it is. And that, we've already, my fear is that the first thing the legislature will do is say, well, let's not do the 1% this year. Let's not do that 0.16% this year, because we don't want to squeeze other state agencies out of funding. I mean, 2% is a very significant shift in the budget. If you look over, as I have, at how the states funded various priorities, whether it's education, social services, public safety, et cetera, fairly consistent for decades and decades. Although, education's been getting an increasing percentage of that over the last decade. So if you have 2% less for everything else, it's definitely a big impact. And then you add that to what's happening with current employee healthcare, and I don't know, I mean, we could model that, but my guess is you might be looking at 4% or 5% squeeze.
Dave, do you have anything else to add?
No.
Thanks for the brief. All right, thank you, Representative Bombach.
Okay, so we've done SB 175, we've got 1% of the budget, we've got the 0.36%. Spoke in at the last meeting, we need to have a written formal plan. That together with the other steps will get us in much better standing with the bond rating agencies. So I think we need to, these are easy. This is the low hanging fruit that we've already got. So let's chalk them up and let's keep moving the chains forward across the field. The OEC ramp up, especially with the adjustment requested to say, let's not scare people with 10%. Let's see with these baselines, with this baseline, how far do we need to go up? Maybe it's just 2%, maybe it's 2.5%, something like that. Let me back up. We said today 85% is our goal. Let's not have any more debate about it. 85% is our goal. Doesn't mean that we give up if we get it to 84.5 or anything else, but let's not keep talking about that. It's 85%. That's my suggestion. Now, this whole thing about percent of the budget, extremely important issue. If it was raised in the beginning of March, I'd be all in on talking about it now, but we're 4.5 months in. We have 6 weeks to go to the end of August. I do not want to see us going down a rabbit hole on this thing. We have 4.5 months in working on percent of getting that gap addressed. Let's finish that job. And if someone has to come back and look at that piece, that's fine. We've already said that half of the OPEB comes from pre-65 retirees, and we spent all of our time on 65 plus retirees plan design. Okay, we've already said we're not doing the whole thing, so let's not kid ourselves and let's not cherry pick. We want to hit this issue versus that issue. We as a subcommittee have been meeting diligently week after week after freaking week. Okay, let's finish the job we've been working on for so long and not get diverted. Thank you.
And the issue for us here, okay, the issue is, I think, as Paul indicated, we have, when you think about it, and one of the things I said at the end of each meeting, sometimes people feel like we haven't done as much. We really have done a great deal. And I think, Jeff, your point was well taken in conversation with the secretary, you know, delving into a little more detail behind with the design, into Paul's enthusiasm. We are going to make sure when we walk out of here today, a couple of things that people who wanted to speak get a chance to speak, obviously. But number two, that we have clarity for those who have to come back with the modeling. I want to make sure Willis Towers, Margaret team, Faith and her team have clarity on where we are next. Because we're getting there. I think we're very close to having some really models that we can vote on. Kristen's looking at me like, are we gonna have to add another date in August? I'm reading you across the table. That is something we will have to make a decision on, you know, if we have to add a date or not. Yeah, Wayne.
Along with the representative's idea, I move that we set the goal at 80%. Making that as a motion, and I'm looking for a second.
I don't know, do we want to, okay, go ahead. Second discussion, motion is before us, and second, any discussion or thoughts? Go ahead.
As discussion, again, if we're talking about OPEB liability gap between assets and liabilities, promises and assets. So far for months, we have been looking at Medicare age portion of that, which is only half of the dollars involved there. I don't think we need to solve 85% in only that size. So I think that going less than that at 80 is more than fair. Frankly, I think 77.5 or 75 is also valid, but I'm support Wayne in this motion.
Jeff and I have been talking about 75, but you know, I'll support.
I think over a 30-year, I mean, can I speak?
Yes, you can.
I think over a 30-year period, picking a target that's below the pension fund ratios is a mistake, but, you know, so I'm not.
Dave, you want to say something? I see
I won't
Dave.
vote for that.
I know Dave, and I know your color and your.
Yeah, so I,
Six observations, and I'm like, he really needs to talk here.
So after some comments I've heard about this, I did some research, and when you look at best practices on funding pension plans and OPEB plans, you fund to get to 100% over a 30-year period. Now to set 85 or 80, whatever, it's fine. But if we get up to 100% of the annual required contribution, I think that's the most important thing.
Exactly. If you want to pick 80%, but hitting 100% of the actuarially defined contribution in the next decade, I'm fine, because we'll probably end up getting to
You know, enough-
So is this,
But you
okay,
can't,
so,
you know, if I had $5 billion, I can get to 85, but I don't have $5 billion.
Okay,
You got
so-
it year by year.
clarify, and if Wayne, he has a motion here, does he need to amend his language someday?
No, I'm just letting you know that, you know, we need to get to 100 at some point in time.
But we all agree to that.
We
Amen.
need to get to 100% of the
And I'll
actuarially defined contribution.
I'll reinforce two things. One is all the stuff we've gone through over the past 4.5 months does not talk about how far along we're getting on ADC in 10 years. Okay, so we can't at this point say that's now something we need to be not recommending until we have that solid, unless we're going to meet daily in the next month and a half. Okay, so I yes, should it come, should it follow? Sure. Should we be saying we can't proceed until we have that and we have to go back on all these models and get that figured? That's foolish. And the other thing, again, we're only looking at one of the two populations, 50% of the spending of OPEB. That alone shouldn't be responsible for getting us on a path to 100%, right? So,
And that's what we're looking at.
and I spoke with somebody who was on the RBSC, and they said, because the RFP was coming up, they focused on a Medicare age population, but they knew there was more work to do. We, I think, can do the same thing. We have been super focused on Medicare age. We're getting to 80% with that. Oh my gosh, the funding is obviously for both, but 80% is more than fair, my mind.
So, any other discussion online from anyone? Anyone? Okay, everybody online is quiet today. Okay, because you all are here. So we have a motion before us. Wayne, would you like to repeat your motion so they have it written correctly?
I move that this subcommittee set the goal for funding by 2052 to be 80%.
Okay. Minimum.
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 And no requirement to hit the actuarially defined contribution.
No,
So we can amend it with that language. Okay, so with the question before us, all in favor, signify by saying aye.
Aye.
Nays,
Now,
one no. Any
No.
other?
Ron is enough.
So Ron, you've been very quiet.
And
like
Lieutenant
to
Governor
listen.
Claire, I'm
Okay.
abstaining.
Abstaining, okay. So Ron, were you saying something else? No, okay.
No, I'm just saying I like to listen.
Okay, all right, you'd like to listen? Good budget director with 2 years. All right, so having received the required sufficient number of votes, the committee hereby sets as a minimum attribution goal of 80%. Okay, now that we have that number for our ratio, Faith, can you take us to our remaining items? And Mr. Secretary Geisinger, you were able to get through your slides.
there was another slide I just wanted
Oh,
to share with you.
Okay, go ahead. Yeah.
So the first slide is no additional trust fund contribution. So this shows what happens to the GASB liability and the trust fund over a period of time without those contributions. The second chart shows with the 1% and the 0.36%. A very similar chart again that was looked at by the Retirement Benefit Study Committee. The red line is showing you the, what you've actually achieved over that 30-year period. You actually don't reduce the under this scenario, you really don't reduce the actual existing OPEB liability. I mean, it kind of hangs out at that $8 billion level. As we discussed, I think at our first meeting, that $8 billion, I believe the unfunded liability for the pension fund is 1.4 billion. All the state's other debt is 2.3 billion, something like that. So your unfunded, even over the 30-year period with just that as a funding solution, which, as we discussed, means you're consuming at least 2% more of the budget, you still don't reduce the underlying OPEB liability. You bend the curve, so it's not growing as fast, but it really doesn't reduce the liability itself. So again, an argument for if we want to be consistent with the Retirement Benefit Study Committee, and it sounds like we don't, but if we do, one of our goals was to bend that curve and reduce that liability over time, not to zero, but to bend it so that it was more in line with the state's other liabilities, so that we don't rank, with what is essentially the second or third highest unfunded OPEB liability of any state in the country. Again, an argument for looking at design and eligibility, although if this committee feels that consuming more of the budget is the right thing to do, then yeah, we could bend it by increasing the funding even further.
But I think we've heard, right, that people do recognize the design issue as well as the funding. Anyone have comments or questions? Anyone comments or questions? Anyone? At this point then, okay. But thank you for highlighting that. It kind of is why we have 3 columns over here, right? Funding, design, and eligibility, 3 areas that we're working on together. So with Faith, you want to proceed, there was just a couple, I think, anything else.
Really just other business, which I believe we probably been handling throughout today's discussion.
And the thing is, whether we get to the vote on August 10th all the way, we may not. I think we may have to move that a little bit.
Well, yeah, so perhaps, thank you, Lieutenant Governor, that may be something we want to spend a minute or two on, which would be slide 15 and the remaining dates that we have scheduled, which are only 2 in August, September the 24th. Recognizing it's high vacation time. I know it's difficult to coordinate schedules. Would be interested, though, I think, in getting some input from the group on whether or not we should be attempting to add additional dates, and then any sense of when you would be be interested in trying to schedule those.
No, I'm sorry.
No,
No, I'm thinking, we're not gonna probably do the actual vote on the 10th, and maybe the 24th begin, and then maybe we have to add dates in September. I don't know. I mean, I'm willing. I'm
just gonna
available.
throw out, perhaps we meet on the 17th of August as well, and, 3 consecutive
Right, yeah.
weeks.
Yeah.
I
We
mean,
can check and
it's
see.
killing me, but I serve on 3 other subcommittees.
What happens when you retire? No, I'm joking. Some of us aren't retired
You
either.
won't get to leave. I
Live in a meeting.
have a meeting after this meeting here, so.
Sounds familiar, right? Sounds familiar, live in meetings and work. We'll have to check and see.
We got really challenged this week.
Okay, so you're saying hard to get the data
Well, we're
back.
just saying like, when you've noticed between meetings that were 10 days apart, we were really struggling to get the material
Well,
done.
no,
September,
my-
But let me add, we may be in the phase, that we're not looking for more
Well,
models,
that's
we just
right.
need time
If
to
it-
talk,
That's what I'm
right? Is
saying,
that
if
fair?
it's modeling, we've gotta space them out.
So maybe we can check our schedules on the 10th and maybe call them, bring some coffee in or something. And maybe make it a 3-hour meeting versus 2 if necessary on the 10th, or if your staff can, don't have your staff shoot me. Where is your staff? That's,
I'll withdraw my suggestion.
yeah,
Maybe we schedule 3 hours on the 10th and then decide whether we need a.
or the 24th if it doesn't work on the 10th. for
Following
people.
week.
If it doesn't work for people on the 10th, maybe look at the 24th, add in, if your team is able to do that. I don't want to speak for DHR.
it really is up to this subcommittee. Those, the 10th and 24th are already on schedules, so, it seems to me
Probably-
there's some value in maybe just trying to
Adding an
expand
hour
it.
to each.
Yeah.
If we can, I don't even know if I can, but we'll try. If not, you take that over with Senator again. So, all right.
All right, yeah, we'll bring coffee.
Yeah, but
We'll circulate
wanted
the
an adult
coffee
beverage.
sign,
Faith wants an
coffee and
adult
snack
beverage
sign.
with
up.
this.
Just so it's not.
She probably needs that adult beverage. For Faith, but-
Snack.
Okay.
Right, we'll look at that, and then if we have to add, we can add in September probably. If we have to, I'm hoping not, because we're getting to the end of our models now. I think we're at the end and hopefully can really digest numbers and make some really solid recommendations on options. Our goal, solid recommendations on options to go to the general assembly governor. So we have time now for public comment, if anyone this time.
Okay, so nobody had signed up prior to, did anyone? We have the. We're gonna start with the people that signed up, and then we'll go to anyone in the room who didn't sign up, but with just a comment, and then we'll go to online.
Right, and for those are, and actually, we might pop into anybody on online too, to be, you know what I mean, to be fair.
Yeah, we're just, I guess.
I don't know
we're
how
just
many we have.
Following the procedure that SBO usually uses,
Okay,
but we'll go to them.
All right, that's fine.
And please keep your comments to 3 minutes or less, just so that everybody has time to talk. We have 5 signed up and it looks like 2 online have raised their
Okay.
hands.
All right, that should get us there, and again, thank you. All right,
Okay, so Connie Roulette.
are you on there?
Not yet.
Not yet, they would be on it. And then maybe perhaps,
Can we start?
folks that, yeah. I can stay till like 12:30, I can say that.
Straight time, 30 seconds.
And for those who perhaps don't get to speak, we are keeping the public website that's available where we're trying to put everybody's attachments, comments, testimony, so that it's there, open and accessible and very transparent. Okay, so why don't we get started? Honey, you must be first.
I must be first.
Hand it up.
I walked right in and signed up.
Okay, so is it Connie? For the record, say who you are.
I'm Connie Merlet, and I'm a co-founder of Rise. My husband is John Kowalko. More on that later. When I bought my first car, the only thing I said I didn't want was red, and I ended up with a red car. When I bought my first house, the only thing I said I didn't want was a split level, and I ended up with a split level. And I learned to love both of those things. Insurance, however, was different. We got full comprehensive coverage on the car and replacement insurance for the house. Because that's what people who have enough money do. Everyone wants choices, but if we have enough money, we always opt for the better plan. As workers, we got the PPO plan, as I'm sure the state workers in this room have. And we told our children when they had their jobs to go for the PPO plans in their jobs, and that we would help them pay for it if they could not. Medicville is the top plan. Only those with less money would opt for another plan. So when I hear you talking about plan L, plan this, people are gonna go for the best plan if they can afford it. So this is really about equity. John wasn't able to make it today because he had his last chemo session on Friday and he's not feeling good. He has B-cell lymphoma, 100% curable and terribly expensive to treat. And I have to wonder what we would be doing if we didn't have the plan that we have right now. Choices are important to all of us, but obviously caveats have to come with choice. And they go beyond the scope of this committee. Most of them. Choice in a health plan has to have underwriting in place so people can change plans. Has to have adequate education for retirees and everyone else, to be fair and honest, and obviously the SEBC needs oversight. I think some of the disagreements about plans comes down to what we're actually talking about, whether we're talking about health care or if we're talking about health insurance. We need health care. People need health care. What we have at present is fair, adequate, and equitable. Nothing else comes close to it, and nothing else is equitable. Which is why RISE has also asked for coding for more than 1% in the budget. I do have John's statement. I know everybody wants to talk, but I can pass it out to you guys.
Thank you.
And
We'll do that and we'll put it on the record.
It's more on RISE's needs and wants.
Great. Okay. Next up is Alyssa Diller.
Hi, I'm Lisa Diller from RISE, and this is deeply personal for me because I can tell you, other than maybe the people in the HR office here, I've spent thousands of hours on the computer emailing with people from all over who were terrified about what was happening. And during that entire time, nobody said to me, with the exception of one person, I really want a choice in what I made for my health insurance. No, what everybody said was we want Medicville or that type of plan, because that's really what's taking care of our needs. So the idea of choice makes sense only when there are good choices. But I think the retirees in this room, the retirees that are listening, the retirees that are spread all over the United States who have emailed RISE to express their concerns, all of those folks really want the type of Medicare plus the supplement that we've had so far. Thank you. It's really simple.
Thank you, Councilwoman. You don't always get applause as a council person.
Or Reverend Doctor, you can do that.
Yeah, Reverend Doctor. That's true, Lisa. We need your prayers, hon.
Julie O'Connor.
Hi, I'm Julie O'Connor. I'm a current employee. I'm a high school teacher, just finished my 28th year.
Woo.
And hearing all this conversation, I'm one of those people that Representative Overly talked about, current employee. You know, I've served faithfully for this amount of time. I'm hearing now if I don't retire by January 1st of 2025, you know, I might not be eligible for this. And I'm kind of in that catch-22. I don't have my 30 years in by that point, and yet I've served. So I don't know, and yet I also hear the secretary saying, you know, eligibility issues. I don't know if something maybe on years of service may be a consideration. You know, and honestly, I don't know after 30 years if I'd be ready to retire right at that point.
Well, you look young and you love teachers, so.
Actually, I have all those points. Another concern, as Representative Overly said, is the cost of things. I would like to, if I became ill, I would like to have the choice to be able to go to Penn or Cooper or Johns Hopkins. These are regional hospitals. And I feel like, with Medicare Advantage, I might be limited to just what is in state. And we're a small state, so, I could easily see monopolies or very little choice available. So that is something else I think that needs to be addressed as well as cost.
Thank you.
And even as a current employee, that's a concern as well.
Thank you.
Okay, Dale Swain.
Right here. My name is Dale Swain. And one thing that a lot of us have had to learn very quickly over the last year is when you would watch TV and see all those Medicare Advantage commercials, it always sounded way too good to be true. How could they be offering all of these things plus more, and you were going to get the same benefits? As we've had to learn rapidly over the last year, you don't get all those same benefits. And it seems like, why would anybody ever want to be in Medicare Advantage if they understood what it's really going to? So I definitely concur with what you said. I would love to see Medicare Advantage taken off the table, not just for the already retired, but to not even offer, period. It just seems cruel for people to find out they need the services and it's not available. So that's my 2 cents on that point. The other on the choices, I can't say that I'm totally against there being choices, but as a 20-year-old, many years ago, taking a low-cost plan when you were very unlikely to have major surgeries seems like a good idea. I could save money. When you get to be 65, it's just a matter of time before you're going to need those expensive options. You don't have 30 or 40 years of being able to have the lower cost options. So for me personally, I would want to be with the current Medifil that does provide the best coverage. I can't say that there shouldn't be available for others, but it's not the best choice when you're 65 years old or older. So that's kind of my 2 cents on this. Thank you.
Thank you.
Okay, Senator Peterson.
Thank you, Madam Chair. Members of the committee, I just wanted to refer to a couple of slides, not all of which were discussed at length today, but I did go through all of them this morning. There's one that talks about state employees making $50,000 a year and can afford to pay substantially more in healthcare premiums. That's laughable. Paraprofessionals and clerical workers make about half that amount, and the overwhelming majority of them are women, and that's who will get hit the hardest by some of these proposed changes. Benefits and premiums should never be based on age at retirement, as proposed on various slides presented to this committee. They should be based on years of service at retirement. Otherwise, a person with 30 years of service could end up paying the same as a person with 10 years of service. In addition, retired state troopers would be penalized because they're required by law to retire at 55. Why would you want to punish them? And finally, I'm not opposed to choice either. I'm opposed to Medicare Advantage ever being one of the choices because it is not a benefit in the eyes of the law. In the eyes of the law, a fringe benefit is a form of compensation over and above wages. In this case, it's free. There is no compensation over and above wages. It's a plan I can get for myself on the open market for free. How do you even consider that as a benefit? Why would it even still be on any of these lists? I have no idea. And finally, in response to one of Tasher's comments, Plan F is not going away for those of us who were born in 1950 or before. That's a whole lot of us retirees who still qualify for Plan F. So please don't take that off the table. It doesn't have any deductibles. It's actually identical to Medicare. I don't know why that would be taken off and Plan G plugged in instead. That does have a deductible. Lots of us qualify for Plan F. So please leave that on the table. Thank you.
Thank you.
Mary Graham.
I'm Mary Graham, and as I'm sitting here trying to read my notes, I'm so happy that I am on Medicfill because next week I'm going to have some eye surgery that hopefully will help. And I haven't had to worry about going to Wills to see the best person and having prior authorization. So I'm really thankful for that. I have submitted comments about what I view as the long thinking about Medicare Advantage as a choice for all of you who are sitting here, and I'm not going to repeat it. I've sent it to these folks, and I think it will be put up online, so maybe you can see that and see my thoughts on that. But I wanted to start, first of all, with thanking Ms. Allen and those of you here, I know Mr. Tasher, maybe Mr. Emsley, who raised and had read through those minutes and caught what I think was a little sneaky insert there that some members had supported the choice of Medicare Advantage. And it's so important that these minutes are accurate. I can tell you, having gone through hundreds of minute pages, lots of hours to look at the past minutes for the SEBC and the RSBC or RBSC. And it's really important what's in there. So thank you for catching that. And Mr. Geisenberger, I know you said that that was an accurate statement that some members supported the choice. But you know, there's a reason why when you're in court, you swear to tell the truth and the whole truth and nothing but the truth. It's because the whole truth, the context matters. And that is not a complete truth to say that some members supported it. I believe that many did not. With respect to, I also appreciated that Mr. Giovanello from WTW made the comment that the premiums are inflated. They're set too high for Medicare retirees, and I think that's important to remember. Anytime you're looking at these financial documents, and I think they should always flag if they're based on premiums as opposed to actual medical claim costs, because it makes a big difference. And it makes the problem look like it's 2/3 to Medicare retirees when it is not. With respect to self-funding, and Mr. Tatner, I know you've raised the question of getting separate insurance. And I've thought about this a lot. And you might think, because I and others have been so actively engaged in fighting the state, that we would say, yeah, let's get out of the self-funding and maybe get away from what folks are doing to us. But you know, in the end, this is Delaware, and we have return day, right? So people come together, and as much as it has been a lot of work and it's been adversarial, I would rather come back at the end of the day and have the recourse in Delaware that we have and getting together and sitting around in rooms than trying to deal with somebody who knows where from Highmark or any other insurance company. Good luck getting change from them. So I would suggest you be very careful about that. With respect to goals, I sent you my email, and I'm so appreciative to hear you all today actually say, let's set goals and then meet those. Thank you.
You Joan Delpatore.
I am Joan Delpatore. I'm a retired professor from the University of Delaware. Most of the conversation has focused appropriately on the difference between Medicare Advantage and Medicare Supplement. But every now and then we hear that we should include Medicare Advantage as a choice because it's similar to what the current employees have. They already have network, in-network, out-of-network. They already have pre-approvals. So why not offer the choice of a Medicare Advantage program that has the same characteristics? It's not the same. Sometime when you have time, go online, go to the Highmark Blue Cross Blue Shield website and look for a provider, let's say a cardiologist in Philadelphia who's in network. First thing you get is a pop-up box that says Medicare Advantage, yes, no. And depending on which of those you press, you get a longer list or a shorter list. And by the way, there are two different lists. There's one that's local and there's one that's Blue Cross Blue Shield's national list. Both of them, the providers who are available in network to the current employees are far more extensive than the network for Medicare Advantage because the providers don't like Medicare Advantage. Johns Hopkins is a good example that was mentioned last summer. It wasn't in the Freedom Blue PPO plan, even though it is in the current employees plan. Also, the same is true of pre-approvals. Again, please don't take my word for it. Check this out. I took the Medicare Advantage contract that the state signed with Highmark last year, and I compared it with the Highmark comprehensive plan that is available to current employees. I have a list of the differences. I'll send it to you. It's humongous. A big thing is cancer care. Retirees would need pre-approval for much more in cancer care than the current employees would. So for the union people to allow current employees to have the impression that if they retired and went on Medicare Advantage, it would be essentially seamless is absolutely not true. I'm going to limit what I'm saying to current retirees, but I hope the reasoning would extend also to others. For current retirees who retired after July 1, 2012, we pay 5% of our premium, which is a whopping $24 a month. Does anybody seriously think that it's in the best interest of those retirees to say we need to make it possible for you to pay less than $24 a month for a far inferior plan, and that's in your best interest? I don't see how anyone can say that. And even though those retirees who are involved and know what's going on are told, well, you could pick the plan you want. No, I am a citizen of the state. I pay taxes. I vote. I have a right to say what I think my state should do. And I don't think my state should take an inferior plan, wrap it up in gold tissue, put a pink bow on it, and see how many people you can get to take it. It is not right for anybody, and I hope you will see that. Thank you.
Tom Pledgey.
Look at the legs move. You're over 60, you're over 80. It's so people's legs move. Right, so I want to thank each and every one of you, Lieutenant Governor and the whole committee. You're doing a hell of a good job on raising these issues.
Did y'all hear that?
Important issue, really. If you were in this room a year ago from now, you would have heard some bull. You would have been told, right, Bill? Do you remember hearing this? I wrote this down. Medicare Advantage is the same as Medic-Phil. It's that the truth, folks. That was told by the cabinet secretary, by the budget director. We've got it on tape. It was also mentioned that all retirees must go with Medicare Advantage in order to get the program through. Is that the truth? Not as of the last meeting, the cabinet secretary said she had 600 to 2,600 people who she wants to give a Medicare Advantage program to. Well, you can buy a Medicare Advantage. That guy Brian from WTW was it said, yeah, you can do it. It may not be as reasonable as you could get for everything, but they gave us twice. Okay. Now I've got a concern. It's a serious concern because what I'm hearing now is retirees will be grandfathered. Retirees will be grandfathers. The Lieutenant Governor and the Secretary DeSantis said that. It was in the Delaware State News. And by the way, that reporter is watching this today. This came up in the meeting. Okay?
Wrong party.
They both said that. Right? What does that mean? What does it mean to be grandfathered? I'm already a grandfather. Okay? So my concern is I don't want it to be a statement.
Excuse me, sir, we have to post this publicly and it's gonna cause a lot of editing issues because we're gonna have to
We
edit
know
that,
what
so,
it is,
yeah.
okay? You don't want it. So if I could make one recommendation, it would be at the next meeting, besides following up on Paul and Bill's great and Jeff's work on asking for modeling. Start with the goals that you want in your report. The first goal should be retirees will be grandfathered. Vote on it. Okay. The second goal is Medicare Advantage is not the route forward, and vote on it. Then spend the rest of the time. Thank you all.
One more in person, Georgina.
Georgiana. I hadn't planned on talking quite, I have no notes or anything. Retired fourth grade teacher, 35 years.
Oh, thank you.
Best job in the whole world. And probably there are a lot of teachers in here too. But I've been texting with my kids as it's going on, taking notes and stuff. And I have two children, a boy and a girl. And I have wonderful daughter-in-law, son-in-law, all work for the state. Thank you. Okay, but helping them and texting them that possibly retirees now are going to be grandfathered they are scared. They want to know what's going to happen to them. Now, they have 15 plus years in, but they're not near retiring. They were given a contract when they signed up to work for the state, 2 of them in school districts, 1 a corrections officer, 1 IT for the University of Delaware. And they took lower paying jobs because they love children and they love what they're doing. But they were also offered this kind of benefit when they retire. And I think not taking that into consideration and also grandfathering in people that are now working, giving them the same benefits that retirees have now is wrong. You're cheating them. You're not being honest with them. And like my daughter said, a lot of people are probably going to leave and we can't afford to lose teachers so at all. It's hard enough to get them in classrooms now. So I hope this committee, and thank you for your work, thank Rise for its work. We wouldn't be here if it wasn't for them. I hope that you will consider people that are now working and protect them too. Again, thank you for your work. Thank you. Thank you.
We have to move on the line. They've been waiting patiently. So Steve LePage.
Yes, can you hear me?
Yes, we can.
Okay, great. I just wanted to say that I agree with all the statements that the retirees have said. It's been very well thought out and presented. I am a believer in choice, but I'm a believer in choice with a caveat. Okay, I believe in choice so that I don't presume to know what is best for everyone else. I presume to know what is best for me and my family. Now, with that being said, the choices have to be good choices. They have to be. Otherwise, you're not really presenting people with a choice. So this is why I agree with what has been said by the retirees. The other issue is it looks like we've talked about the payroll contribution of being 0.36. I want to remind the committee that prior to Governor Carney, who reduced the payroll contributions by almost 2/3, Governor Jack Markell had the payroll contribution at 0.90%. I don't understand why 1% cannot be had again. I think you guys are getting closer now, maybe finally, to figuring out this budget thing, and to Secretary Geisenberger's point about reaching the ARC. I think if you guys go and you're looking at this funding, and you're trying to get to 80% or 85%, I think that's good. But then there will come a time where maybe you can introduce Bob Clarkin's idea, where you start utilizing the ARC as a funding source. Because eventually over time, the plan will pay for itself and the state won't have to kick in as much. So those are my comments. I think finally, after, like Representative Bomback said, after so many months, I think we're really getting to some points here. So I just want to thank you all for your hard work.
Thank you, Steve. Okay, next up, Diana Noonan.
Thank you. I want to express my appreciation to the committee for recognizing the need for the state to honor its promise concerning retiree health care. I do have an ongoing concern, however, regarding Medicare Advantage being offered as an option. I believe that Representative Bumbaugh, I'm sorry if I kill your name, has said that he believes in choices as long as the choices are good ones. Medicare Advantage is not a good choice or alternative for retirees, current employees, future employees, or future retirees. The argument that there are 600 retirees who want Medicare Advantage is a weak one. They were presented literature describing Medicare Advantage that held, frankly, true, false, and misleading statements. The questions of co-insurance, co-pays, and cost sharing still exist as Highmark has never outright addressed what these categories entail. Employees and retirees cannot make a valid decision if only faced with incorrect information. I believe the 600 noted number quoted as retirees who want Medicare Advantage must be an arbitrary one. The idea that people want Medicare Advantage because they can't afford a monthly premium is absurd. First, it has been stated in this committee that's likely Medicare Advantage will eventually have a monthly premium. Secondly, if you cannot afford a monthly premium, how will you afford co-pays, co-insurance, cost sharing that could amount to thousands of dollars? Medicare Advantage has the probability of costing retirees unmanageable and unpredictable sums compared to a Medigap premium. Additionally, I do not believe the 600 potential Medicare Advantage retirees justify the cost involved with marketing and offering Medicare Advantage as an option, just because a small number might prefer it. Let's be honest, they are not the reason that Medicare Advantage is even on the table. This committee was charged to offer a plan with comparable coverage. The multitude of pre-authorizations causing denied coverages, delays in treatment, or lack of coverage for treatment is in no way comparable by anyone's standards. All over the country, there are states who are reporting high and inappropriate numbers of Medicare Advantage pre-authorization, and in some cases outright fraud. The state has a multitude of unfilled positions. You will get what you pay for. If you want to hire quality employees, you will have to treat potential employees with respect. Lastly, in no instance that I am aware of does a consumer benefit from having a corporation stuck in between a consumer and a product. To put Medicare Advantage, in other words, privatization of our Medicare between us and Medicare, a program that we have paid into for our whole lives, is not good business, nor is it advantageous to the retiree and in the end, the state. As someone mentioned, if the state has no skin in the game, how does Medicare Advantage constitute a benefit? Plainly, it does not. Thank you.
Thank you very much. And if members need to leave, we are past 12, I'm able to stay. But if anybody does need to, out of respect to those who are with us, we certainly understand.
Tom Penoza.
Hello, can you hear me?
Yes, we can.
Okay, thank you. I want to thank everybody too for all the work. I've been following what you've been doing. And I want to thank Representative Oberle for his comments, because that's what I wanted to talk about. What he said was, we were told what we were going to get when we were hired. I was a Newark police officer for 22 years, and they didn't offer me health care in retirement. So when a job opened up as a special investigator with the state, that's one of the big reasons I took it, because I knew I was going to get this healthcare after retirement, and I was going to get a supplemental plan when I went on Medicare. I paid into Medicare for over 50 years, knowing that I had an agreement with the government that I was going to get Medicare. And then once I worked for the state, I knew that I was going to get a supplemental plan that would make up the difference in what Medicare didn't pay. So about 6 years into my retirement, I find out that in fact, I'm being pushed into a Medicare Advantage plan without even knowing about it ahead of time, and not being able to even be involved in any comments on it. I know I don't want a Medicare Advantage plan because I spent 3 years in our Medicaid fraud control unit with the state. And we spent a lot of time in nursing homes. When you're in nursing homes, you work with people who are on Medicare. They're all, some of them are on Medicaid because they ran out of money, but they're all on Medicare. And I got to learn firsthand the problems they had with getting these elderly people treated. You know, their families were having problems and all. I've never wanted anything to do with it. And I made sure my mom and my mother-in-law had supplemental plans to go along with traditional Medicare. So I appreciate what you're doing, and I request that you vote against any kind of Medicare Advantage plan. I don't think it should be offered either. It's a bad choice, and especially older people are going to be looking at the cost and less looking at the list of rules and regulations that come with it. So I thank you again for your work, and I request that you not put any kind of Medicare Advantage plan in effect, and at least leave us with what we were promised when we got hired. Thank you very much.
Thank you.
Linda Hastings,
Hi, can you hear me?
you can.
Great. Okay, I want to talk about something that nobody's brought up yet, and that has to do with the current contract that the state has with Highmark for Medicville. So far, there have been 6 amendments to that contract, and I believe it needs a 7th. Currently, if unless I'm missing it, I believe that the most recent amendment only extends it through next July. And if we're not to end up being stuck and somebody say, oh, gee, we don't want to leave you with nothing, here's the Medicare Advantage contract. A 7th amendment needs to be made so that that contract is extended from July 1 to December 31, 2024, and that needs to happen soon. The second thing I wanted to talk about is the upcoming RFP that will replace the contract that I'm saying needs to be amended. There will be an RFP for the next contract. And the decision that you all are making, the recommendations you all are making, will apply to that next RFP and contract. And so I'm already worried about that, particularly the upcoming RFP. I take a look at what happened with the problems with the minutes from today. And that is, there's different people sitting around that table and they hear what's gone on in the meetings differently. And the people who will be responsible for writing the RFP, I am concerned about the way they hear what the recommendations are going to be. So I would like to ask this committee to not think of your work as being over at the point where you finalize your recommendations, but that you continue to plan your meetings so that you can review and approve the upcoming RFP before it is released. Somebody will release it without you seeing it. There will be stuff in it, and then they'll want to say, oh, we're legally obliged. No, it needs to be right before it goes out. Which gets me to the point of echoing Tom Pledgey, that you all need to define what grandfathering means. So I think I know what it means, and that means that we will continue to, those of us who are retired will continue to get our Medicville type healthcare. But others of you say, oh, it's also going to mean choice for the current retirees. What is it? So far, you don't think you know what it is, and I don't know either, and I'd like to. With regard to skin in the game, we've been paid less than the surrounding states. Employees have already put skin in the game. Now you're looking for more. I think you're making a mistake.
Okay. Bob Clark.
Hi, can you hear me?
Yes, we can.
Thank you. I don't want to repeat what everyone has already said, because I don't think I can add much to what they've already offered. So I have a very, what I hope is a simple request of the committee, and hopefully this won't require any modeling. And that is, over a year ago, I went out to the mailbox, got the mail, came back, and there was a letter to me and a letter to my wife congratulating us that we were being moved from the Medicville coverage to a new Medicare Advantage plan. And I had seen all the commercials on TV that everyone else had seen, that it's free coverage and it's greater than anything you could possibly want. But what infuriated me was I was completely blindsided by that letter. I had no idea that that was coming. So I think what I would like to request of the committee is to think about this, that once you reach the point where you're going to issue your report and it's written and it's signed and it goes to the governor and the legislature, At that same time, you would mail a copy of that report to each and every retiree that would be affected by what's in that report. And that would be what we think of as traditional state employees, but it would be all the affiliated groups also. So it would be all the schools, all the school districts, all the charter schools, University of Delaware, Del Tech, Delaware State, everybody, every retiree that would be affected by that would get a copy of that so they could read it and they could see what might be coming down the pike, whether it's a choice or no choice or what the choices are. And I think you also need to send it to every single state employee, no matter who their employer is within those affiliated groups, that's going to retire within 5 years so they could see what's coming down the line for them when they retire. Because I think it's very important to be very transparent with what the report says and let every single retiree and every state employee that's within 5 years of retiring know exactly what the future may bring. Thank you.
Thank you very much. Don't have any other testimony at this time or for folks, but our Commissioner Allen, you have your hand up. Need you a new title, Commissioner, for your committee. How about that? Denise, you want to unmute?
Oh, okay. I thought somebody else had their hand up. I'm sorry.
I only see you.
Okay. So my question with, I'm listening to all these comments, and I know you all have been inundated with the emails that have come in, especially over the last 2 weeks since our last meeting. Our next meeting is not for 3 more weeks. What do we need to do to motion to take the Medicare Advantage off this table? Because it is so evident that is unwanted, unneeded. I feel like we are just spinning our wheels saying the same thing. We haven't had one person, not one email, not one public comment to support this. And so I don't know how we get a motion, or I don't know how it works.
Well, by parliamentary procedure, we're at the end and we have lost official members of our voting body here and online. So it would not be appropriate at this time to call that question, but that is certainly something at our future meeting. I mean, that is certainly your prerogative, and that is certainly something that could be brought forward at a future meeting. And so hold your thought. And certainly we can bring that forward then. Thank you, Denise. Thank you for that. Any other comments from my co-chair, Senator Townsend or Representative Baumbach?
Could I ask that we put this Medicare Advantage question on as the item of the next agenda?
We can certainly have it as an agenda item to discuss. All right.
Motion adjourned.
We have a motion to adjourn. Do I have a second?
Second.
All in favor, so nobody saying aye. Aye. Ayes have it.
Aye.
Thank you all. Let me get it first. There you go.